The DSM is, of course, America's official diagnostic manual for what constitutes a mental disorder and how it's to be diagnosed. As such, it's a pretty powerful document. It influences what kids get special attention in schools, who gets medications, who gets disability, whose criminal responsibility might be mitigated, and who gets research funding. It's prepared and published by the American Psychiatric Association, but it should be noted that it is in fact essentially America's version of the International Classification of Mental and Behavioral Disorders published by the World Health Organization. There was in fact actually no DSM prior to 1952, although psychiatry had been in existence actually for 50-some years. In 1948, the World Health Organization agreed to create a uniform diagnostic system for mental disorders after the experience of the problems of its absence during World War II. So the 6th edition of the ICD was the first to actually include a section devoted to mental disorders, and DSM-I was America's version of this international system published in 1952. There was an ICD-7, but it had not included a change to the mental disorder section, so there was no reference to the DSM. DSM-II came out in 1968. DSM-I and DSM-II were really not particularly innovative documents, but the presence itself was significant in finally having a common language for psychiatry and psychology. But the 1960s and 1970s were also a time in which the diagnosis of mental disorders was receiving really severe criticism. You had leading psychiatrists like Thomas Saz and psychologists like David Rosenhan arguing that all of this is really just a myth. A major innovation came with the DSM-III, published in 1980, chaired by Bob Spitzer. Its major innovation was the inclusion of much more specific and explicit criterion sets versus these vague, general narrative paragraphs that were in DSMs 1 and 2, and this really increased the ability to conduct replicable scientific research. Now that may not sound like much now, but it really was a big step forward from the inferential diagnostic approach of DSM 1 and 2, which is really dominated by psychoanalysis, in which the diagnosis would emerge through the course of analysis. So it's a much more clear shift now to empirically based, replicable scientific approach. DSM-III also included a couple of other innovations. One was the multi-axis system, where mental disorders are diagnosed on axes 1 and 2, physical disorders on 3, stressors on 4, and global assessment of functioning on 5. This was an effort to get psychiatrists to recognize that a person's problems are not really just simply confined to their mental disorder. There was also greatly expanded text, providing empirically based information on course, family history, correlates, etc., which conveyed a much stronger scientific basis for the validity of the disorder's existence that were included therein. Now, DSM-III was highly successful. Every psychiatrist, psychologist, social worker, nurse in this country, and frankly many other countries, wanted a copy. So the profits really simply from the sales of the DSM led itself to the development of a major publishing company, American Psychiatric Press, which is probably now the leading publisher of books on the etiology and treatment of mental disorders. A difficulty, though, with DSM-III was that there really was inadequate research to guide many of the decisions of what diagnostic criteria should be included and what disorders should be included, frankly. In some cases, like, for example, the personality disorders, the diagnostic criteria were created de novo. By the time DSM-III hit the stands, research on the criteria sets were now, though, revealing significant problems. So Bob convinced the APA to publish a revision of the DSM-III. It was not intended to include new diagnoses. It was not being coordinated with the revision of the ICD, so its name was 3R, not 4. But given the tremendous success of DSM-III, it was probably unrealistic to expect little change. DSM-III made a lot of people famous and helped to spark actually a new major focus of research on diagnosis. Everybody wanted to be involved in DSM-III-R, and everybody who was involved wanted to have a big impact. So in the end, DSM-III-R actually included a number of new diagnoses, some of which were really quite controversial. 4 proposals were in fact ultimately vetoed by the American Psychiatric Association's Board of Trustees: paraphiliac rapism, premenstrual dysphoric disorder, self-defeating personality disorder, and sadistic personality disorder. These 4 diagnoses all share the feature of being potentially harmful to women. So, for example, paraphiliac rapism or sadistic personality could be used to help mitigate the responsibility of a man who rapes or abuses a woman. And self-defeating personality disorder could be used to blame the woman for being abused. There was also really inadequate research to support their validity, and certainly little to no research to address these concerns. Bob Spitzer was put in charge of DSM-IV and 3R in part because of his success in resolving the controversy over whether homosexuality was a mental disorder. But I have to say, I think Bob also really likes controversy, and he had a pretty low threshold for what could be included in the DSM. As he always said, if a group of clinicians came up with a new diagnosis, they felt they'd seen it in their clinical practice, and they could come up with a criteria set that would allow it to be diagnosed reliably, he would include it in the manual. DSM-TR, I think, really revealed an inherent problem. The decisions are not being made by neutral scholars. The decisions are being made by a small body of leading investigators who have a very strong interest in their proposals to include them in the manual. They're concerned primarily with a lack of coverage. They're really not that concerned with other issues about overdiagnosis or excessive medication or stigmatization or public health care costs. And I think this is really probably a fundamental problem. Now, DSM-IV was published in 1994 with Alan Francis now as the chair, and one of its mandates was to have a much more conservative threshold for inclusion and to have good empirical documentation. Along with the DSM-IV itself, the APA also published 4 DSM-IV sourcebooks. These sourcebooks included 175 literature reviews, 36 data reanalyses, and 12 field trials. The field trials tested alternative proposals for a particular mental disorder, compared the proposals to what was already in 3R, and compared to the ICD. And each of these studies also included external validators to determine which proposal was optimal or whether or not it would increase, decrease validity. All the reviews and proposals were submitted to critical review, often to peer-reviewed journals, and all the reviews had to have a structured format. This was to ensure that the authors would not confine their reviews just to their own research or just to the findings that supported their viewpoint, and that's really a common feeling of all literature reviews that are not subjected to critical review. I have that one fourth one in the source book with that shocked face there because I don't think the APA is actually even publishing anymore. So when I wanted to get the picture of it, it's not really available. Now, this external review emphasis is really a fundamental and a component really of good productive science. Critical review helps in a lot of ways. Frankly, we do all have preconceptions. I don't really call these biases. I just call these opinions. But our opinions will affect how we interpret things, how we perceive things, and the proposals that we make. It's also obvious to get critical review simply to catch silly mistakes. And it's also really good to anticipate future criticisms, that you can anticipate them and address them in advance. As Marco Corleone said, keep your friends close, but your enemies closer. And one example of this in 4 was the participation of Bob Spitzer. He was the chair of 3 and 3R, and for DSM-IV he attended every single work group meeting. And frankly, in all honesty, he was a real pain. He pretty much opposed most every proposal. Now, keeping in mind, work began on DSM-IV in 1988, and DS-3R came out in 1987. So there was really no reason to expect Bob Spitzer would support a revision. I mean, these were his proposals that he had made in 87, and he certainly wasn't that excited about immediately changing them in 88. But as such, he really was an outstanding foil in the work group meetings and a tough hurdle to overcome. Now, our current version of the manual is DSM-IV-TR. TR stands for text revision. There were really 2 related reasons for this revision. One is that by now the DSM is actually being used as a textbook in some settings, and the text certainly should be as current as possible. That is, the discussion of family history, age of onset, and so forth. A more cynical view, though, is that the American Psychiatric Association just wanted another series of sales as big as those they had done in 1994 for DSM-IV, because they do make tremendous profit. So in any case, DSM-IV-TR was not to include any new diagnoses, was not to have any changes to any criteria sets, but was only to update the text description. However, an innovation that was planned for DSM-IV-TR was to have the text now include citations, like any other textbook in the class, documenting the empirical support for the statements that were made. But these goals really were not fully met. There was, in fact, in the end, a change to the criteria set for pedophilia in response to some criticisms that were made for DSM-IV. So they actually raised the threshold for the diagnosis of pedophilia. And the intention to document the text never actually happened. There were a few problems with that. Some persons simply actually just refused to do it, who were doing the updates. It's hard to get these leading investigators to do this sort of work. Some of them did clearly a very poor job, and some of them confined their citations pretty much to their own research. And that would obviously not be what you would want to have in a diagnostic manual. So rather than have poor documentation, it was ultimately decided not to have any at all. Now, work began on DSM-IV, the forthcoming version, in 2006, which was really 12 years after DSM-IV was published, so a lot of time had passed. The chair is David Kupfer, the vice chair is Darrel Regier, and originally it was scheduled to be published in 2011, which would in fact obviously be this year. But there's been quite a few problems have occurred with respect to the development of the DSM-IV. And I expect to some extent the existence and importance of these problems have been exaggerated or escalated by the existence of the internet, where we can then generate immediate discussions. But there certainly are quite a few, and I'm going to talk about each of them. One problem is the confidentiality agreements. To this day, it's not really clear what this actually refers to or its intentions. But every work group member had to sign a confidentiality agreement. One view is that it was just a way to maintain proprietary rights over what is being included in the DSM. But a common view is that the work group members are not being allowed to discuss their deliberations outside of the work group meetings to review inside scoops or disagreements that they're having. Now, this led to disgruntlement of Bob Spitzer, the chair of 3 and 3R. He was actually denied access to the work group minutes. For DSM-IV, he was invited to attend all the meetings. For DSM-V, he wasn't even allowed to know what was being discussed. So in the letter to Darrel Regier, he wrote, "It is clear from my own experiences trying to ask about what is going on with DSM-V that many task force and work group members are interpreting this confidentiality agreement to mean that they are not allowed to discuss any details about the process with colleagues who are a part of the DSM-V. Now, this was not a trivial concern. In May of 2009, the chair of DSM-V said at the meeting of the APA, "As you can see, the clock is ticking, and we need to begin these field trials really very soon after the APA meetings, because we really need to complete them by 2010. So if you wanted to have the DSM-V come out in 2011, certainly you needed to get the field trials done, and in 2009, he said, let's get going, we need to start the field trials soon. But at this time, none of the proposals had yet been revealed to the field. DSM-IV, they were all vetted to the field prior to the field trials, but this had not been yet the case for DSM-V. As David said, most of us involved would like a couple more years, but we know that's not going to happen. So then Alan Francis, the chair of DSM-IV, and Bob Spitzer, the chair of 3 and 3R, sent a joint letter to the American Psychiatric Association's Board of Trustees saying that the experience so far with DSM-V has proven what should have been obvious from the start. A secretive and closed DSM process simply cannot function properly. We strongly recommend that you immediately open the DSM-IV process to full transparency, DSM-V process to full transparency. Scrap all the confidentiality agreements. Actively recruit a large circle of advisors, especially those who are most likely to spot the serious problems that will be created by many of the suggestions for DSM-V. Now, it isn't really known why the schedule was then pushed back, but soon after this letter was sent, the field trial was in fact postponed to 2010, and the proposal was then posted online in February of 2010. And the field trial was delayed until after they got some feedback from this open posting. The revisions to the proposals were posted again in January 2011, got some more feedback, and more revisions to many of the sections. However, because of this significant postponement for the field trial was cut from a two-stage process to a one-stage. It was originally going to be two-stage, where you collect a bunch of results, and then you do revisions, and then you'd field trial the new revisions to see how they work or if they work any better. But with a delay in the implementation, they really scrapped and just going to have one stage. There are some problems for the field trials themselves. The field trials are not testing alternative proposals, nor even collecting data concerning DSM-IV-TR. This is really in stark contrast to what was done for DSM-IV. The DSM-IV field trials were critiqued by the NIMH. The DSM-V field trials were an in-house project receiving no external review. They're not going to collect any data on validity. We're not going to even know how the revisions will impact prevalence rates because there's no comparison to DSM-IV. There will be no test of whether the revision increases or decreases validity. It will just be confined to feasibility, perceived utility, and inter-rater reliability. And there are reasons to be concerned. DSM-IV is proposing lots of new diagnoses, many of whom are really rather risky and controversial. Temper dysregulation disorder of childhood, paraphiliac coercive, which refers to a serial rape, hypersexual disorder, pedohebophilia, mixed anxiety depression, non-suicidal self-injury, and others. I'm going to talk about a few of these in more depth in a bit, but I'd be happy also to talk about others when it's opened up to Q&A. There are also other major proposals beyond simply adding diagnoses. There's a proposal to reconceptualize substance dependence as a behavioral addiction, and moving into it then, pathological gambling. So addictions will no longer be confined to a drug or a drink that you ingest. You could also include this diagnosis to refer to many other behavioral addictions like internet addiction, shopping addiction, and so forth. There's also a proposal to delete the bereavement as an exclusion criterion. So you can diagnose somebody with a major depressive disorder after they've lost their family or their child to some tragedy. They're going to delete half of the personality disorder diagnoses, and it's actually a proposal to delete all of them and redefine them as variants of Axis 1 disorder. Now, DSM-IV has posted an outstanding document on how the decisions should in fact be made, what sort of empirical support should be provided. This was co-authored by Ken Kendler, David Kupfer, the chair of DSM-IV, and others. It's posted online. You can get it at www.dsm5.org. As they say, for example, proposals should include a discussion of possible unintended negative effects of the proposal if it is made, and a consideration of arguments against making the change should also be included. The larger and more significant the change, the stronger should be the required level of empirical support. And I will say some of the reviews are really excellent. I refer you, for example, to the review for the proposal to include a diagnosis of hypersexual disorder. I think this review covers very well all of the various concerns that would and should arise for such a proposal, which could include things like preoccupation with porn, going to strip clubs a lot, and things of that nature. And again, there's the address for the proposal. All of these can be found at www.dsm5.org. But other reviews I don't think are really so much excellent at all. I would encourage you, in fact, yourself to go to the website and check out the review for mixed anxiety depressive disorder or premenstrual dysphoric disorder. They're very limited, very cursory. They're not following the recommendations of Kendler. One example I would give is the proposal to change substance use disorder to this broader behavioral addiction and then folding into it pathological gambling. This is a very major revision. We'll open the door to all sorts of new addictions like internet, shopping, computer game addictions, so forth. The review is confined to what you actually see on the screen, these two sentences. And then after these two sentences is a list of references which they suggest are supporting of the proposal. In fact, many of them aren't really even that significantly related to the proposal. An additional problem is the criteria for including a new diagnosis. There's long been really a debate about what the threshold should be for the inclusion of a new diagnosis in the DSM. In DSM-III and 3R, as I suggested, Bob Spitzer indicated that if any group of clinicians said they see this condition in their patients and they can come up with a reliable criteria set, then he would wind up including it. But that, of course, led to a lot of controversial proposals that were eventually vetoed by the Board of Trustees. In DSM-IV, the attitude was a disorder really needed to meet a threshold of validation to be included. The DSM is perceived by the general public, by the field, as an authoritative document. People look at it as a list of validated constructs. But this really doesn't appear to be the case now for DSM-V. As the vice chair of DSM-V said, Darrel Regier, that's what the DSM is, a set of scientific hypotheses that are intended to be tested and disproved if the evidence isn't found to support them. David was lamenting that it's hard to get researchers to obtain the necessary data for the validation of a proposal or a new diagnosis. So he feels the DSM should be used to actually stimulate and encourage this development of this research. An example of this is the proposal to include a new diagnosis of temper dysregulation disorder of childhood. Its purpose is to address the existence of an overdiagnosis of bipolar disorder in children. Currently, right now, there's no criteria set for bipolar disorder in children, yet the diagnosis is increasing substantially in prevalence, and a lot of kids are getting the medications for this. Now, a new diagnosis with restrictive criteria might diminish the overdiagnosis. but it would also provide a perceived credibility and perceived validity that doesn't really in fact exist for this diagnosis, leading then probably to more diagnoses or at least an unfounded credibility for the diagnosis. And even more troubling, the work group recognizes that the empirical support for this diagnosis is really flimsy at best. In a joint statement of the Mood and Child and Adolescent Disorders work group, they said, both work groups are concerned by the fact that the work on severe mood dysregulation in children has been done predominantly by just one research group in a select research setting. But they still nevertheless want it to be included in the DSM. As they say, the new diagnosis will help jumpstart the research on severe irritability in youth. And again, you can get all these documents yourself from the DSM-IV website. So in the end, the DSM is being used to generate the research that is needed to actually validate the proposal. All of this has led to a lot of bad publicity for the APA. Susie Chapman has a blog in which she's posted a lot of the various critiques and the controversies involved. Petitions have been developed. There's been a number of critical reviews in scientific journals, which has led sometimes to a cutting back and scaling back of some proposals. And Alan Francis, the chair of DSM-IV, now has his own blog, his own on the DSM-V called DSM-V in Distress, a blog posted through his site today. Personally, I have to say, I think he's getting a little carried away with a lot of his role as this outspoken critic, but I think a lot of his comments are really well taken. So that's it, and I thank you for listening. These are 3 slides of images from my neck of the woods. I hope you appreciate all 3. And I'm also posting here, which I believe you can get on your own when it gets off the screen, of some additional readings if you're interested in pursuing this on your own. Thanks a lot.
So Tom, our first question is, do you think the DSM-V will come out in spring 2013 as people are talking about now?
Yeah, that's a real good question. Many people wonder about it given really the controversies that's being generated. They've also experienced some difficulties with the field trials. They're not getting the results that they actually were hoping to get. The reliability values are lower than what they had hoped to get, and some of it just isn't really working. And it's not terribly surprising that that would be true, but that is what I hear is happening. So there's some thought that might delay it another year, but I'm predicting that it will not be delayed another year. I think they already delayed it 2 years, and I think they're very uncomfortable with pushing it back any further. So I think it will come out, in fact, next year.
Okay, thanks. So our second question is, what's your opinion about the proposed changes to diagnosing Asperger's syndrome and autism diagnosis just in general?
Yeah, that's one of the many ones that's gotten a lot of attention in the media. It's difficult in part in that it involves actually a number of different proposals. So they're expanding the whole concept of autism to include these autism spectrum conditions. But the key diagnosis itself, they feel is not being fundamentally changed. But there's already been a study that received a lot of press in the New York Times indicating that the threshold for the central diagnosis of autism is perhaps being increased, and so that a lot of kids who are currently being diagnosed with autism would not continue the diagnosis. Now, that doesn't apply to things like Asperger's or the less severe variants of autism. It only is the more severe one. It's an ironic controversy because most of the controversy surrounds a concern of expanding the boundaries of these disorders, diagnosing more children with various conditions, getting more kids on medications that are probably harmful down the road and may not even be that necessary. But in this case, the primary controversy is that the possibility that the threshold is being raised, and so a lot of kids with these severe forms of autism may no longer qualify for the special attention in their treatments. Not too sure exactly what's going to happen in the end with the threshold. This is, again, part of the problem is that the field trial isn't really comparing using DSM-IV criteria to the DSM-V criteria to indicating how it may impact prevalence. This study that get a lot of attention was done by somebody outside the system, and the members of the child disorders work group responded to that and claimed that it was a faulty study, that the threshold for autism is not really being changed. But again, the field trial really should be collecting that data itself.
Great, thanks. So next, one person actually had a comment and a question. The comment is congratulations on the NCAA win.
Yeah. I was hoping I was going to get something like that. Yep, I'm very happy about it. I've got a couple of basketballs signed by all the players, and couldn't be happier. Although all of them left. All of them left yesterday. They all declared for the pros, but what are you going to do?
And then the question. This is from an instructor for intro psych students at the University of Indianapolis. And they ask, would asking students to come up with hypothetical diagnoses and criteria be a worthwhile exercise? Just your opinion on that.
Well, yeah, it would. I think there's different ways to do it. In all seriousness, one can do it. What's an interesting, when one does an exercise like this, what's kind of interesting is that you can pretty much make up just about anything, and some people make the criteria for it. And you get a sense of, gee, how easy it is to really do this, and then potentially how harmful it is to do this. I mean, you know, if you get diagnoses like sadistic personality disorder, where a group of psychiatrists said that they see this, they come up with the criteria, now people meet the criterion, and you put it in a DSM, and it gives it some sense of credibility that this thing exists, but it was just these people just simply made it up out of thin air. I did an annual review of psychology paper about the time of DSM-IV, and I was provided in this paper a list of all the various new proposals for DSM-IV, but I embedded in that list some phony ones that I just made up as a joke. And then to further disguise, well, then at the end I asked people, can you identify which ones are unreal? And then to further disguise it, I actually had some phony references by them. Now, the copy editor to the journal didn't really think that was funny because, and I didn't think about this, hadn't anticipated this, that, you know, students are going to go try to track down some of these references and they don't exist, and that's going to be very frustrating. So I did wind up putting a footnote in the article indicating which were also the phony references as well as the phony disorders. But it's an interesting task. It's not that hard to make up a new disorder and then have to see people meet it, meet criteria for it. So yeah, I think it's an interesting exercise.
Great, thanks. So our next question. If the DSM-IV does come out in 2013, do you think clinicians will continue to use the DSM-IV-TR as a textbook when teaching and possibly compare it to the DSM-V with the underlying message that the DSM-IV-TR is still the main book used for diagnosis?
No. Once the DSM-V comes out, clinicians have to switch. They don't really have a lot of say in that. It's actually in part governed by the insurance companies. They have to make the switch. Now, at what point? Well, it's a complicated question, and to some extent, in that ultimately what we have to use is the WHO's ICD. So when America switches over to ICD-11, we then have to make the switch. But clinicians will, I'm sure, pretty much right away make the switch to DSM-V simply by the coding system. I think it'll happen pretty quickly, and so they will have to do it in a fairly quick rate once the insurance companies say that now they're using the new ICD-11 codes, which would then have to be the DSM-V coordinated with it. But I also think a lot of people just simply be interested in it. It's because it is going to have a lot of new radical ideas. I don't necessarily disagree with some of the ideas that are in there, you know, shifting the DSM to a dimensional trait model. But my problem, again, really is just the lack of care in considering the negative consequences and problems that might arise from it, the research documentation, the literature reviews and such. But again, I expect, yeah, some clinicians will continue to use DSM-IV, but they'll be simply compelled to get, if they want to get insurance coverage, to switch to the DSM-V. I remember when DSM-III came out, a lot of clinicians were still using, you know, DSMs 1 and 2. The clinicians that can be slow to shift to a new nomenclature, but DSM-III was so innovative, people really got very interested in it and moved fairly quickly once they started noticing it. I think that will happen with DSM-V.
Thanks, Tom. So next question. When revising the DSM, is research from across a variety of ages, cultures, and genders considered?
Yeah, that's a very good question, and it's a very difficult issue. I think actually one of the innovations of DSM-IV was to try to deal with this in a more explicit fashion. There's a lot of ways this is kind of strange in the DSM. DSM still has a section for childhood disorders, and it's kind of in some regards that makes sense because some disorders are simply confined to kids, and you don't see them in adults. But in some cases, it's really just the fact that there's a specialty in psychiatry and clinical psychology of child clinicians. And so they really just talk to themselves. They don't really pay much attention to what's going on in adult psychiatry, and those working with adult psychiatry don't pay much attention to what's going on in child. And so there's really no real good communication between them. This led to a lot of really kind of funny things in the DSM-IV-TR and 3 that you'd have like anxiety disorders in childhood, let's say over-anxious disorder of childhood or avoidance disorder of childhood, and then when you hit 18 years old, the disorder either disappears or it becomes some other disorder. That's just sort of an odd anomaly, that there's just an arbitrary switch in your language when you hit the age of 18. And there was also an odd thing that it's still true for DSM-IV, is that there aren't really any mood disorders of childhood. There's just mood disorders. Now you could say that's a good thing because you then apply the mood disorders of adulthood to kids. But there's that controversy about bipolar. Should you apply bipolar to children? So DSM-IV tried to deal with some of this by folding some of the anxiety disorders into, I'm not going to call it adult disorders, just the disorder. So over-anxious disorder of childhood became generalized anxiety disorders. So when you look at generalized anxiety disorder, it says in childhood this disorder looks like this, and that was DSM-III over-anxious disorder. And DSM-IV has a disorder of social anxiety disorder, social phobia, and it says in childhood that looks like this, and that was what was originally DSM-III avoidant disorder. So ideally what you'd have is a disorder, and then you say what it looks like in children, what it looks like in adults, and also obviously what it looks like in an aging population. But they're really far from really being able to do that very effectively. There's a push to try to do that in the text for various disorders, but there's not sufficient amount of research to really do this well. Certainly it's not I'll have to say it's not a requirement of DSM-IV field trials to collect data on age differences. It's limited already in what it's covering, so they're certainly not covering developmental changes and such. But I would say that criticism would apply as well to DSM-IV. It's just we just don't have the research on how these disorders vary across the lifespan. That's really only been starting to be recognized as an important consideration in the last 10, 15 years. I don't know if you made reference to cross-cultural, but the same issue applies to there as well. There's a section in DSM for how the various disorders appear across some cultures, and then there's also these cultural bound syndromes in an appendix. But we really don't have good research well enough to do a good job about discussing that.
Thanks, Tom. So next question is from an instructor. So my abnormal psychology course is focused on the current DSM-IV, but I would like to expose my students to the possible changes coming with DSM-V. Do you have suggestions for how to do this, or do you think it's best to focus on the DSM-IV in class until the DSM-V is finalized?
Well, I think it's worthwhile to discuss some of the controversies. And it's not hard for the class to be able to get access to these things. You just, again, like I say, you go to www.dsm5.org, and they have a website with all the various proposals. So, I think the idea of possibly changing substance use disorder to behavioral addiction, no longer it's an addiction involves an ingestion of a substance. That's an interesting topic. I mean, historically, everybody always used to think, incorrectly, that drug dependence was a physiological dependence due to changes in the brain resulting from the ingestion of a substance. The field really changed actually beginning in 3R, away from that towards a broader concept of a behavioral dependence. And now DSM-IV has taken the major next step to say, yeah, and pathological gambling is just like any other, like a drug dependence, like an alcohol dependence. These are all behavioral addictions. And that's an interesting issue and a topic for people to talk about and try to wrap their heads around. And certainly the topic like saying that, you're mentally ill if you're still depressed significantly over the loss of a loved one 3 weeks after their death. DSM-IV is proposing no longer include bereavement. So I think there's a lot of, topics that I think students can readily wrap their heads around and understand the controversies, and I think they'd be interested in a lot of these controversies. So I think it's well worthwhile to actually, you cover DSM-IV, but then you sort of indicate, here's the major possible change here for DSM-V. And to see those for each one, it's not hard to get them on the website. Although it is true, nobody's actually listed, for each DSM-IV to sort of what the big controversy is for each one. You'd have to kind of click around on the website to find all of them, and that would take some work. But I think getting 3 or 4 of them, I think, would really stimulate good class discussion.
Great. Next question is, you mentioned some concern about some of the new diagnoses. What are 2 or 3 of the ones that concern you most?
Well, I think I have talked about the ones that concern me the most. I would, like the temper dysregulation disorder of childhood. I think that's potentially very harmful, particularly since they're explicitly embracing the idea that you only need to have just a few studies and one research site would justify its inclusion, that they're actually going to give credibility and authority to the diagnosis in order to generate the research to validate it. This is particularly risky disorder because this will encourage a lot more kids to be put on these medications. And keep in mind what this is. I mean, bipolar disorder in adults is pretty straightforward diagnosis. It's not hard to see it. It's not hard to diagnose it reliably. But what they're suggesting, they suggest that the version in childhood is temper dysregulation. That is, would be kids who have lots of explosive temper tantrums. And so that really looks different from the swings between mania and depression. If that's really the same, is that a childhood version of bipolar? I mean, it doesn't even look like it would be the same thing. But they have no data on what happens to these kids with this temper dysregulation when they grow up to be adults. Do they actually have bipolar as adults? I mean, I kind of doubt it, but there's certainly no research on that. And so they're going to have the diagnosis in the manual to generate the research. And I think that's really very risky. There's lots of other stuff that has, potential risks. One would be the pedohebophilia. They're going to raise the threshold for pedophilia 2 years. So I forget the cutoff, to be honest with you now. I think it's 12, and I'm going to raise it to 14. Now, don't quote me on that. Or it's 14 to 16. That's an interesting point because you think about this cross-culturally. We have a pretty, relative to other countries in the world, we have a high threshold for when age of consent for sexual activity. And they don't have, let's say, in Italy and France. So they would say that's fine in Italy or France. We would call it a mental disorder. So that's an interesting issue. Another one that doesn't perhaps ring bells for people is this attenuated psychosis. This comes out of it's certainly a well-meaning, well-intended wishes that if you could identify people in the prodromal phase of schizophrenia, that is before they become psychotic, and give them treatment, medication, you may in fact prevent the psychosis from developing and ultimately really essentially save their life from the most severe mental disorder that there is. So they want to create a diagnosis called attenuated psychosis. And what that would essentially be is the prodromal phase of schizophrenia becomes a disorder in and of itself. What they don't really appreciate, and this gets back to the idea of you can just create a diagnosis and see how it works, is that once you create a criteria set, you're going to find a lot more people meet the criteria for that criteria set than those who actually have this syndrome. This was true for schizotypal personality disorder. That came out of identifying features you see in biological relatives of schizophrenics. you create the diagnosis of schizotypal PD, and then when you administer it in the field, probably only 10% of those people who meet criteria have a biological relative with schizophrenia. The vast majority do not. The vast majority have nothing to do with schizophrenia. So it's really misleading to suggest they have some form of schizophrenia. And I think the same thing's going to happen with attenuated psychosis. They're going to get a lot of people who are pretty odd and strange, but they really aren't, you know, in the prodromal phase of schizophrenia, don't really need to be on medications, and don't really have a form of schizophrenia. And again, that type of research really needs to be done before you include the diagnosis in the manual. So I think that's a pretty risky one.